Oh, good afternoon to everybody. I'm very pleased to be here with you. And in this webinar, we are going to share with you a little bit of our experience as a WHO Collaborating Center, as a network of risk managers and clinicians working at the sharp end. As experts in human factors, we try to follow a systemic approach in the design of this webinar. So we will present different aspects and views through the intervention of each panelist. And I wish to thank all the colleagues for the precious contribution. I will start saying that the last few weeks, our work, as you can imagine, changed a lot. We had to move from a planned work to a rapid response support to the network of our risk managers, but also to the operators at the front line. So we are trying to use our specific expertise in human factor to facilitate work at the sharp end. And we are mainly supporting the healthcare organization in the design and implementation of some practical tools that can be used in specific settings of care for supporting clinicians, especially from the cognitive point of view, when they have to perform risky actions during the emergency. And as long as new needs arise, we are ready to design new solutions in strict collaboration with experts of prevention and protection services and experts in reorganization of clinical pathways. This collaboration is very important. And just to give an example here, some examples here in the slides, you can see the poster for the description of dressing the personal protecting equipment together with the algorithm for putting on and removing the PPE. And with the same approach, we adapt and diffuse the WHO material dedicated to healthcare operators. And also, in order to reduce the overload of info at the sharp end, we transform documents related to organizational issues into easy-to-read material based on usability and ergonomic principles. And here you have on the left an example related to the procedure for admitting and managing COVID-19 patient in setting as home care that is being translated in a visual clinical pathways. That is very useful for people at the sharp end. In collaboration with the network of risk managers, we also promote some priority actions in support of the emergency. The first one is to trace reports of the critical issues related to the emergency in order to provide an immediate response, but also to give a memory to the organization. And this is an active role. Risk managers actually walk into places to collect stories and problems. And Michela Tanzini will talk more about this issue later. The second action is a proactive assessment of risks. New risks can arise due to the continuous reorganization of clinical care pathways and according to the different phases of the crisis. Also, risk managers have this zipper function, let's say, because they are the point of conjunction between the line and the management and coordinate and integrate the multiple instructions, lots of instructions that we have every day, so that can be put in action at the sharp end. They continuously monitor also the correct application of infection prevention practices, and they are actively involved in training for PPE. PPE are a hot issue. For the official data that we have say that 5,000 health professionals got infected. That is 10% of the total number of people infected. And what we have seen at the very beginning of the emergency was a lack of a single coordination line or centralized control for the management of this special equipment. Instead, some hospitals adopted this best practice from the very beginning to change the way PPE were managed, centralize their distribution, and create a contingency plan for their management during the emergency. The other critical aspect is the ergonomic of dressing the PPE. It is a very complex process, and there is a need of adopting a multimodal approach for training. integrating different strategies and in our hospitals, the risk managers combined 3 different actions: video tutorials, simulation sessions, and posters on the walls to support the actions on the slide. Actually, simulations should be the best way to grant the procedures become part of the expertise of the healthcare workers, but this has to be done in time of peace. And we made some consideration about preparing for emergency in time of peace. We believe that risk managers, experts in ergonomics and human factors, experts in quality and safety should play altogether an important role in preparing for emergency from the time of peace. And there are some key points here that will be covered by next panelists. The first one is related to the community engagement, the role of reporting and learning system, the design of the hospital preparedness for the organization of services, the promotion of safety culture for COVID-19 and key sectors like surgery, and the use of simulation as a key learning tool. Thank you.
Good evening to everybody. I will start talking about social distancing and community engagement campaign realized in our region, recalling first the timeline of the Italian response to COVID. On January the 31st, WHO declared the public health emergency of international concern. And the same day, Italy declared the state of emergency after that 2 Chinese tourists resulted positive in Rome. On February 18th, the National Institute of Health reported the first case of second-generation transmission in the Lombardy region that, along with Veneto and Emilia-Romagna, turned to be, and still is, the most affected region. On February the 23rd, a sanitary cordon was indeed activated around some areas of Lombardy and Veneto, and there an emergency task force was formed in order to lead the outbreak. At this time, we had 221 positive cases. So in the following days, increasing restriction and social distancing measures were imposed to the population according to the regional epidemiological situation. But on the 8th of March, our Prime Minister declared the national emergency, and the entire country was declared red zone and the population was quarantined. At this time, we had 12,462 positive cases. When the containment measure entered into force in Italy, we were well aware from the experience in China that early, rapid, coordinated, and comprehensive implementation of social distancing measures are likely to be more effective in slowing the spread of the virus, of course, than delayed actions. And then the effect of social distancing measure is likely to depend on how early these measures are taken in the context of the local epidemiological situation. But our government opted for a step-by-step strategy of social distancing and containment, and step-by-step strategies in terms of geographical expansion and in terms of severity of the restriction. As for the geographical expansion, as you can see here in the slide, measures started to enter into force first in several municipalities in the north of the country, then in 3 regions and 2 provinces, still in the northern part of Italy, and then extended to the entire territory. That is the so-called step number 3 of the emergency plan. Also, the severity of the restriction follow an increased process. We started with the closure of schools and public places, then the closure of some non-essential commercial activities, the reduction of public transportation, the closure of several public offices, and the isolation and active surveillance for people that had direct contact with confirmed cases, people that return from international or national epidemic areas, or people with mild symptoms. The measure increased constantly day after day, week after week, until the complete lockdown of the present days. In order to support the effectiveness of social distancing measures taken at the national level, in the Tuscany region, the region where our center is co-located, a massive community engagement campaign was launched with the aim of diffusing all the key messages related to the basic health behavioral rules that came from WHO and from our National Institute of Health. So we start disseminating information regarding hand hygiene and respiratory etiquette and social distancing, how to use protective equipment also for the population, how to use the dedicated phone number to call in the event of the onset of symptoms for a preliminary phone triage. And this was very important in order to avoid the overload of first aids and to avoid the spread of the virus inside hospitals. And of course, we disseminate also the main rules for indoor hygiene, including how to take care of a member of the family positive to COVID and how to manage waste at home. We have to say that all these community engagement material were designed according to human factor principle and with the main aim, as Sara already said, to put into a clear to understand format for the population all the numerous and complex available information that were diffused by our institutional bodies. And we have to say that over time emerged very clearly that the epidemic could not be stopped just counting on hospital capacity to answer to the surge of patients in need of respiratory assistance, but that the role of primary health services was fundamental. There emerged that we need in order to stop the spread of the virus, well-equipped general practitioners working at the community level, along of course with an active involvement of the population, a clear strategy for an early identification of the most vulnerable part of the population, and a strong centralized command line for a proper coordination between community health services and hospital, with the aim to avoid the overload of the entire system and its collapse. Thank you.
Hello, good afternoon to all. I'm very pleased to be here today and share our experience regarding first lesson learned during managing COVID-19. First of all, as clinical risk network, we realized that we were not prepared in managing emergency. In all these years, we have worked proactively and reactively, focusing on ordinary healthcare management. The global scale of COVID-19 challenges has shocked the system as it is, and it became quickly apparent that during the outbreak, implementation and adjustment were necessary. The clinical risk management units must continuously keep in contact with frontline workers and provide support. The reporting of adverse events must occur within the task force activities and be primarily related to the core clinical task in time of pandemic outbreak. Our previous structure, reporting and learning framework doesn't work anymore while coping emergency scenario. The evidence of horizontal communication among healthcare workers is ongoing, including informal network to share information. The reporting of adverse events should still be encouraged for maintaining the underpinning climate safety in order to promote, whenever possible, prompt corrective and improvement action. A health worker should consider quick reporting tools such as confidential instant messages or audio messages. It is crucial to guarantee safety climates and maintaining safe work practices under dynamic and hazardous conditions. COVID-19 offers us an occasion to active pursuit of information, learning and adjusting care practices. Simple human factor methods to be applied are direct observation, debriefing session, info day-to-day decision based on resilient principles. Here are some examples, experience and solutions realized that we are trying to trace in a shared document thanks to daily calls and weekly updating with our clinical risk management network. They are organizational solutions created in different contexts, but they are all immediate responses to new needs and symbols of how our healthcare workers are resilient. The first one regards updating protocol and guidelines. These documents are formulated, created, and implemented in first instance by end user in collaboration with physician, nurses, technicians, and so on, from the health management, in collaboration with the department director and also the referee function, such as laboratory, diagnostic imaging, and transports, and so on. All these contributions are integrating into a single document with specific attachments for leading well-defined actions. Then there is an index to facilitate the traceability of the main topics. All these documents are stored in a dedicated session in the intranet and then disseminated by mail. Identify the operators in the world, explain face-to-face the changes to help reset the cognitive updating of previously internalized information. The second example regards a practice from one hospital in Pisa. It is a daily general director video message. At the end of the day, the general director summarizes activities about COVID patients, successes achieved, critical issues occurring, and the updates of protocols and procedures. This represents a briefing appointment focusing the attention on the most important information of the day. Another issue regards training. Some mirrors were purchased and installed in the changing rooms to allow operators to look at each other during donning and doffing personal PPE for avoiding the chance of mistaking and guaranteeing operator safety. During the procedures, simulations were also made by wearing gloves with ink to increase the perception of risk of how easily one can be infected. A PPE counter, an application was also implemented to count the number of PPE needed for the management of the COVID patient in ISQua to optimize the viability of PPE. The unit supervisor is thus able to make daily and weekly revisions and manage any critical shortage. The last one regards personal linen kit for COVID patients. COVID patients are isolated and their family members are not allowed to bring them underwear and to assure their personal hygiene. So the municipalities donated to hospital underwear, towels, and the hospital have prepared personal linen kits for this issue. Thank you.
Hi, and a warm welcome from myself as well. Good afternoon to everybody from sunny Florence, although in lockdown, I'm afraid, so we can enjoy it. In the next few minutes, we will talk about safe surgery and safety during the present pandemic. Safe surgery is not something that needs to be addressed only when crises happen. Safe surgery is a culture that has to be there all the time. This is my disclaimer. I have no conflict of interest, and safety, as I said, it's everybody's business. So safe surgery is mandatory all year round, regardless the crisis we're facing. This is a message from a dear friend and a colleague from Shanghai on how they dealt and what they did during this, well, it says epidemic at the time, but now we can say pandemic. Strong leadership from central government. They relied a lot on what the government said, and they followed instruction. That's a key issue. A national level medical team set up, so they just were very ready to act and be effective straight away, because they had a culture of teaming up in crisis. And then, of course, as we follow, they had strong confidence, and strong confidence in what they were doing, strong confidence in what they were said to be done, that strong confidence overall, and they were absolutely sure they could be in a good position to fight, and not only fight, to win the pandemic. So what can we do? What can we do as a professional, healthcare professional? Well, of course, avoid non-essential procedures. So that's goes without saying. Like goes without saying, protect health professionals and allocate resources from the COVID-19 patient. Create clear pathways, not only easy to follow, not complicated, and have dedicated COVID-19 wards in order to avoid contacts with other patients. And all aspects need to be taken into the account, from the isolation to the transportation of infectious patients, because this patient, unfortunately, needs to go to maybe theater or to x-rays. They need to move around. So maximum protection and maximum alert around this patient. I'm a surgeon, therefore I concentrate a bit on what's happening in the OR. Well, theater requires great attention. Great attention because few small things can make huge, massive differences. Minimum staff level, it's important to avoid lots of people around. Avoid positive ventilation. Be sure that you close the room, the OR room, after a suspected or a COVID-confirmed patient for 30 minutes to change the air inside, and the disinfection. That's disinfection happens all the time, but in this specific situation has to be a little bit more careful. There has been a lot of debate as a surgeon, a general surgeon, pediatric surgeon. Can we do laparoscopy during this pandemic or not? Well, as everything, there have been two big groups, yes and no, because we don't really sometimes have the ability to understand and work together. So, of course, aerosols generating from laparoscopy or endoscopic procedures can be dangerous and can spread in the theater room, in the theater suite. Of course, we need to be careful, but on the other hand, if we take some precaution, first of all, we select the right patient for the procedure, we are more active on doing so, we can do laparoscopy. We need to make sure we don't have any leaks from our laparoscopy trokers. We use suction-assisted smoke evacuation device. and then trocar stops and lure connector prior to insertion trocars. We reduce the pressure while we're doing the operation, and then the dangerous business is the desufflation. So we need to be very, very careful when desufflation happens, and using simple smoke evacuation system. And of course, when you take the specimen out, whether it's in a small or big specimen, it needs to be in a bag. And don't be curious and have a look what goes inside, because you know very well what's inside. So it's small steps that will make a massive difference if you have to do some laparoscopic work. So we surgeons in general, we have a role to play in this pandemic, and I think it's quite an important role to play by being present. That's important. Communicating effectively and truthfully with our colleagues. We can show our leadership during the crisis and be optimistic and empower our colleague to what is around you. And in this crisis, we have the responsibility to develop and follow plans, be strategic. And that's quite important. It's an extension of the role of a surgeon, but it's very, very important, and we have to do that. Of course, we need to have support from high-level management in order to accomplish these tasks. Knowledge about the disease, it's evolving very, very quickly, and we understand we must constantly adapt and change our pathways. We don't know much about this virus. We don't know much about this problem. So clinical information needs to be disseminated as much as possible. Research is not an option at the moment. We can't just do randomized control studies, so we haven't got time to do so. But what doesn't take lots of time is to connect with colleagues. Today it's very easy to be connected with colleagues across the globe, facilitated by historical links or interaction or the use of technology. There's nothing wrong in using technology and asking advice everywhere. This way of communicating is faster than the virus spreading. And of course, we have people like us who have been overwhelmed by the viruses before others, so we can have a role to play in helping these colleagues. Surgical teams. That's something we developed with colleagues in the UK. Surgical teams, in order to stay healthy, need to have a 2-week rota. And that's important because after a 2-week period, you have a new team coming in, and that will allow easier replacement of team members should they fall ill, or better containment of the virus should the virus spread in a team, which is a smaller team. And while away, the other colleagues are not on holiday. They are just considered that time outside the hospital, not as a free time, as a time to improve guidelines, to do remote working and manage all the aspects of the department they can manage from home of where they are. And so this smart working is very, very important in this moment. We learned a lot. Of course we did. We're learning, unfortunately, because we're still in the peak of the pandemic. But what's the message we learned is planning and preparation. Planning means be prepared for the worst, thinking and then simulating numerous case scenarios, and implementing isolation wards and isolation rooms. Preparation for doctors or for surgeons means being prepared both mentally and physically to the hurdles that you could face. It also involves be prepared to use all the protection and be trained to use the PPE, all the protection. having the possibility of using telemedicine and online teaching to keep the medical students and your junior up to date. And last but not least, of course, update some skills that we use less or we're not very good at. I'm talking about intubation, formation of tracheostomy. So that's very important to an opportunity not to miss. Final message is from all this information I've shared with the college in England and the International College of Surgeons. So the intercollegiate surgery guidance, it's very, very sharp. COVID-19, don't take any chance. Thank you.
Hello, everybody. Thank you for this glad invitation. I'm Stefano Spinelli. Mainly, I act as a clinician during the last months, and really, this is the really first time that I can stop and reflect on my self-practice during this emergency, and this is mainly a great occasion for me. I work in Pisa Hospital. Pisa is one of the main university hospital in Tuscany. And as the other colleagues in Tuscany, we started from a step zero. The step indicated by WHO to us to identify and treat single cases that potentially arrive from abroad or from north of Italy. Giulia showed us really well how our government decided to divide in steps our lockdown according with the epidemiological data, and in our clinical practices we were following the same indication and the same role. We started from our previous experience with Ebola. In the emergency department of Pisa established an emergency plan for potentially infectious spreading disease, looking for that experience that we had. Mainly, the first step was to identify a dedicated triage outside of the hospital, setting up a tent where our nurses were instructed to use a clinical and epidemiological criteria to divide all the cases arriving from the outside in potentially COVID and no COVID. This was really easy to be established with the help of the Italian civil protection, and was enough for an early identification and isolation of the first cases. The staff were trained since the really beginning of the emergency, and luckily for us, we had a couple of weeks of advance to prepare the hospital compared with our colleagues in north of Italy. This is our capacity. This was our capacity to cope, starting from our emergency plan. Was enough to identify sporadic cases, and was enough to dedicate just a few bed places in the isolated area of our infectious disease ward. Unfortunately, at a certain point, we understood, and the national public health authorities understood, that COVID were with us, despite our attempt to control and maintain the disease into a single pathway. And we were forced to change completely our mind from an epidemiological criteria to just a clinical criteria of the identification of the patient. And this was our experience regarding the failure of our emergency plan. The Italian emergency system is established and is well prepared to cope with an earthquake, with a mass amount of patients arriving suddenly in an emergency department, but we have no experience in a situation like this. So we start from our emergency plan, but we understood in 10 minutes that our emergency plan cannot sustain this kind of disease, and we shift from the hospital coping. This is the aphorism from Emperor Augustus. The importance of planning is reducing with the increasing of the scenario complexity, and we are reflecting on this, and we shift to a completely new assessment of our emergency department. We understood, and thanks to the experience of colleagues from Lombardia, we decided to set up just in one night a new emergency department completely dedicated for COVID patients, dividing the spaces in a clean area and a dirty area. Luckily for us, we were able to do that according with our setting, our logistics. We started from the emergency plan of our emergency department. We modified the assessment. We set it up during the night, the filter area for the healthcare professionals, and working with full protection, we established a 30 bed places area able to treat the COVID patients. At that point, we identified a couple of pillars. First of all, avoid the overcrowding in the emergency department to prevent the stress on the healthcare professional and to prevent the in-hospital COVID spreading. And secondary, ensure the emergency care for all, looking for, in particular, for the time-dependent disease as cardiovascular emergencies and stroke and emergency surgery for sure. So we identified into the hospital 2 separated pathways for COVID patients and for non-COVID patients, using a microbiological, the microbiological specimen as leading for our decision, and ensuring the pathway with the same timing necessary for this kind of disease. Meanwhile, we started a clinical reasoning, a clinical training, particularly from the medical point of view, to trying to understand COVID-19 as a disease in terms of our ability to identify the patient and treat it. The main difference in that phase was the triage. We decided, probably before the national indication, to remove an epidemiological criterion to identify a potential COVID patient, and we started just putting all the respiratory patients, all the fevering patients into the COVID emergency department. This was enough to rule out COVID-19 in our patients and send the patient clean into the normal hospital using just the 2 wards, the infectious disease wards and the pneumologist ward as a COVID hospital. Unfortunately, after just 1 week, we understood the number of these emergencies, and we were forced to shift our reaction to another level. The problem moved from the emergency department to the hospital in general, and we decided to build up a proper COVID hospital when the saturation of our bed place was too high. We identified this building, that is one of the main buildings in Cisanello Hospital, to be used as a COVID hospital, defining into the same building 3 pathways. The red pathway for the COVID patient, the green pathway for non-COVID patient, and that is extremely important, a gray pathway for the patient that is waiting for a definitive diagnosis. This is crucial to protect the staff, and this is crucial to protect the other, in particular the green patient, the non-COVID patient, to a potential contagion. 4 wards were reset to be used as a COVID hospital. This means this time to change completely the logistic of our hospital, change the number of bed places. However, the possibility to contain all the cases starting from the emergency department in a dedicated hospital prevented, we hope, the in-hospital spreading of the disease, and so far we had no cases reported outside the COVID hospital since the beginning of the emergency. At the same time, we tried to offer the necessary high-level care for every patient, COVID and non-COVID. In particular, the COVID patients were treated in an area with several levels of intensity and the possibility to be moved in theater or in the intensive care unit directly without any waste of time, using just one building. At the same time, I want to sublime this, that's for me an extremely important point. We try to promote new instruments and new research approach. We are a university hospital, so we had the possibility to set up a data management and data control on our clinical data to promote good practices in our hospital and to promote the information and the clinical data sharing across our country. We have to thank our fellow for that started immediately to set up our database. So now, since 1 month, we are in this condition. We are treating COVID patients in the COVID hospital and non-COVID patients in another part of our hospital, but we are extremely scared about how long this situation will carry on. So far, we decided to stop all the elective surgical activities and all the elective OPDs activities. This is sustainable for a short time. This is exactly what we use in the emergency plan for other kind of emergencies. However, we cannot stop the care for the non-urgent patients so long. And we started to think about the COVID coexistence. And then this will be our new step. I have no solutions, no answer, but a lot of questions for this. We have to move our mind on that, and we will keep you updated. Thank you.
Excellent. Thank you so much to all of you for that fantastic presentation. It was a great talk, a really brilliant insight into your experience and your response to dealing with the virus and what's happened. I'm sure you can imagine, we've got lots of questions coming in, so I think we're just going to go straight into the Q&A. Sara, our first question is for you. I'm just going to unmute you now. So from Simon has asked, how did you manage the quick transition to the new way of working?
Actually, this is the question, because we were not ready. As Michela described, it was very difficult and also as Antonino described, it was very difficult to identify a new way of coordinating and communicating. And this was because we were not ready to manage this kind of emergency, especially from the management point of view, as Stefano was pointing out too. Because of course you need to change, totally redesign your work. So to be honest, what we did was to talk with the frontline, to talk with the risk managers, and try to understand from them the best asset that we could take in order to support them. But there was no a planning at the management level, at the regional level, except for, I have to say, of course, the composition of regional and hospital task forces and crisis units with a multidisciplinary approach. So you have experts of infections, of epidemiology, experts of the different specialties, but there is a lack of presence of the other figures that can help especially in communication. Sometimes in this let's say new teams. And so, of course, we reorganized our work with thanks to our human factor approach by listening to the needs of our network, and also trying to connect also with the other regional departments, focused on what we can do for the front line. And this was the key in order to be responsive. So the lessons learned that we shared, all of us, is that we need to get ready during our routine operations for the emergencies, not just at the front line, but also at the management level, all different management levels. And I don't know if the other panelists can want to add something else to this comment.
Yes, I think, thank you, Sara. I think also, just add something, we are still always a bit behind the COVID. So we are still running and trying to find organizational solution, because I think the main criticality was at the beginning, but still now, an holistic point of view, because at the beginning we focused the attention just at organizing the hospital, but now we are moving the attention to the primary care, to the involvement of the general practitioner, pediatrics, and so on, elderly facilities. And so now we are moving the attention on how to manage the COVID patient on the territory. So it's still ongoing to find the right solution, the right way to manage all these issues together with an holistic point of view, which is quite difficult because we were not used to this kind of integration and collaboration.
Excellent. Thank you, Michela, and thank you, Sara. Our next question is from Yared, who has said, as you know, Africa is the last continent to face COVID-19. What should we have to learn from Italy with regard to social distancing implementation?
Okay, I will cover this answer if the other panelists agree. What I can say is that, of course, as a collaborating center, we have also collaboration with African countries and Middle Eastern countries, and we are trying to give them support in terms of providing some tips, some information on how we are trying to deal with the virus, and but of course we have to consider the differences in the context and the differences in the resources. And what we were discussing with colleagues, for example, in Kenya or in Palestine, is that where the resources at the hospital level or at the primary healthcare services level are limited, social distancing and community engagement is the best things that you can activate, is the most important things, because otherwise, hospitals or facilities are not able to give the proper answer to the surge of patients that can go to the hospital, because they don't have the correct information on how to manage the virus. So what we can say is that providing the population all of the proper information regarding social distancing, hand hygiene, respiratory etiquette, and also and is fundamental, because in this way, and also providing them information on how to behave in the event of mild symptoms, because most of the people are pushed to go directly to the hospital as soon as they feel bad, because they are scared by the virus. But in this way, the virus can enter into the hospital. So better to have direct phone line or text messages system to contact, to be in touch with, in order to have first information how to take care of people with mild symptoms at home. So in this way, you're avoiding overload of hospitals. And in our region, this was very important. As soon as the dedicated telephone number was activated, we were able to provide triage over the phone, and this was a strategy to avoid overcrowded of hospitals. Another important thing is to involve also and to coordinate also with NGOs and associations that are working at the community level, mainly involving them in supporting the population, providing food, kits for hygiene, for personal hygiene and hygiene of homes. Because in this way, you make the population safer, and you avoid the population to go to the hospital. So in our region, NGOs and associations are coordinated at the municipality level. So most of them have been involved directly by the municipalities. Others organized by themselves. There are several NGOs that are working with the more marginalized part of the population, like homeless and refugees and migrants that are in our cities, in order to give them the appropriate information, because also for them it's very hard to find this information. So social distancing and measure for hand hygiene, respiratory etiquette, and so on, involving the population is something very important, especially where the resources at the hospital level are limited.
Excellent, thank you, Giulia. Our next question is from Ilya, who has asked, what are your recommendations to assure safe communication when delivering care in the isolation area or wearing PPE? Would anyone like to take that?
Stefano, maybe you can comment on this with your direct experience. And Antonino.
I'll try to answer. Speaking about just my experience, we use the speakers, and we asked to have telephone with speakers into the dirty emergency departments. I don't know if it could be the solution for everyone. We stressed our staff to prevent any action that move the not clean hands over the face. So we asked to everybody to do not move the portable telephones into the dirty areas, and they are acting in this way. This is just my experience. I don't know if one of you have different.
I haven't got anything else to add. We just more or less the same. We do the same here. Just empowering people not to. The list of things and not to do is longer than the list of you can do. So it's that's how it works. So yeah, avoid touching surfaces, touching yourself. Communication is just a verbal communication or through speakers.
Excellent, thank you. Our next question is for you, Antonino. So pre-op negative COVID test, does it change anything in the theatre? Are you still using full PPE? And what about the risk of false negative testing?
Thank you for this question. It's a very tricky one. False negative is a big issue. We know that having a negative test doesn't mean anything. For the laparoscopic work, we assume people are positive, so we do all the possible precautions when we put in trocars, when we remove the gas. Every single patient goes to theatre. Before going to theatre has a test taken. If it's an emergency operation, so that we haven't gotten time to have the results from the test, is treated as COVID until proven otherwise, and we use full PPE. For people that can wait a couple of hours, of course, the test is important, but doesn't mean that we are more relaxed. We probably won't wear full PPE, but we take all the normal precautions.
Excellent, thank you. Our next question is from John Overtwite. In Stockholm, our activated emergency response management system is superimposed over routine primary and community healthcare operations, and there was some uncertainty about who made which decisions. What did you do to ensure clarity of decision-making, clarity of a decision-making authority at facility level and at higher levels?
So this is a little bit, thank you, John. I'm very happy that you're here with us. And this is a little bit connected with the first question, actually, because it's related to the coordination mechanisms. And of course, at the facility level, as Stefano was describing, but also Michela with the solutions, there are crisis units and task force, and all the communication goes through this multidisciplinary team that update the info and diffuse and communicate the news every day. Actually, even 2 days, two times a day. And but there is a problem in order to understand if all the made decisions have been transmitted to the front line. This is a critical point because there is no structured way to get feedback from the front line, and this was a problem also during routine operations. And so I think this is a point we need to improve. But of course, there was an involvement of all the different transversal functions to like the medical directions and also the infection prevention control team, the clinical risk managers to support the right transmission of communication. But still there are, of course, we were talking about before monitoring and going into the world to see if all the different instructions are put in actions, and this is a critical point. But it was, again, a critical point also before the emergency, to get feedback from the front line and to get all the input from the front line.
Excellent. So John has also asked, regarding the many voluntary services independent from the NHS, how did you coordinate locally and at higher levels so that you maximize impact on key problems? And what special actions for care homes or for older people were taken?
I would make a comment for the care homes, and then I would leave the rest of the question to Giulia and the other panelists. At the beginning, we didn't think from the very beginning about home care. So we were behind the virus in this environment. So that after a while, of course, there was an emergency into the emergency in these clinical settings. And so in few days, there was there were lots of actions taken by the politicians and then at the management level and then at the sharp end in order to control the epidemic in this environment. First of all, a screening for screening to all the patients and all the healthcare operators was performed like in 2 or 3 days. Actually, it was just 2 or 3 days ago. And then there are now strict rules for new admissions to the home care, and also every new admission has to be tested for the virus. And the problem here is also the competencies that you have on the field, because nurses have been hired by the public hospitals because of the emergency, and some of them were had not permanent contract in the home care settings. So now they had to face an emergency with newcomers, new nurses, and so the other solution was to have teams of skilled nurses and clinicians going into the home care, the different settings to train these new people. And there was a lockdown of some home care because of positive cases and some strict measures for isolation. But this is an ongoing process because, of course, now the focus is on these specific settings because of the criticalities in managing them at the beginning of the epidemic.
Okay, I would add something regarding the involvement of private sector and association. So I would say, first of all, that there are two kind of association working in coordination with the healthcare, with the health system. From one side, we have very big associations such as the Red Cross that is working very. That is working in strict contact with the municipalities, with the regional system, and with the civil protection, and that they are offering support both from the health point of view, so taking care of people from the healthcare from the health point of view, but also providing support, as I said before. For taking care of the most fragile part of the population, like elderly, people living at home, people that cannot move from their home because they have disabilities, and so on. So they provide also food at home, kit for hygiene, and so on. Then there is another part of another group, a very big group of associations that belong to the private sector that activate by themselves, of course, still in coordination with the health system, again, to provide the same kind of support. Support from the health point of view and also from the everyday life point of view. And for this sector, and both of them are very much involved in caring elderly people, again living alone, people living in informal shelters, migrants, people living along the street, homeless, and so on. And this is very important because we know that the virus can spread very quickly because social distancing, hand hygiene, respiratory hygiene is very difficult to respect.
Excellent. Thank you, Giulia and Sara. Ilya has asked, is there a change in the rates of medical errors under the epidemic? I don't know if anyone would like to take that one.
Antonino Morabito. I don't think there's been any change. We haven't got, unfortunately, the real figures, but can talk from experience. I haven't seen any on my desk in the last 2 months, so it's quite reassuring. No, there have not been many medical error or drug errors in this phase.
Excellent. Thank you, Antonino. So, oh, sorry, Sara. Sara, go ahead.
Just a short comment. Of course, it is very difficult now to have reports about medical errors because of the situation. So what we are doing is collecting actually with the direct contact all the criticalities and also the medical errors, so also the sentinel events that can occur because of COVID-19. But it's very difficult to get the figure ongoing. Probably we can answer to this question in next month when we will be able to do an analysis of what happened.
Excellent. Thank you, Sara. So I'm just keeping an eye on the clock here. I realize our time is nearly up. So we have a final question here, which might wrap things up very nicely, which is from Sophia in the Saudi Patient Safety Center. Sophia has asked, if we had the chance to rewind back time and do all of this all over again, knowing what we know today, what would you do differently?
Sophia, this is a very tricky question. Who wants to answer?
Can I say something? I mean, as I said during the body of my presentation, I think altogether it's been an eye opener because there's many things we can do to improve the quality of the service we provide, and on top of that, it's very important that we plan and be ready to face whatever could happen. And this is very important for the future. Perhaps remote working in some situation has to be implemented. Online teaching has to be implemented, but training and simulation, I think, has to be top of the list because we cannot be caught out again and not prepared in the event of call it disaster. I don't want to say a virus, a disaster in general. That's what I'm thinking at the moment. But as I said, we are in the middle of it, so we might be still on the learning curve. And at the end, we might be able to reflect and make a plan for be ready. Let's put it this way. I don't want to say make it better, but be ready.
Yes, I would add to this that as we have written several times, we cannot forget that when Ebola was when we had the breakout of Ebola, none of us was thinking that something similar could have happened to us. So at that time, we could have started thinking about how to get prepared for an epidemic, for this kind of pandemic that could also happen here in Europe or in USA or whenever in the world. We always seen this kind of thing. I mean, at that time we saw that kind of things, that kind of pandemic very far from us. But now we are. We have learned that we are all interconnected, that we cannot think that we have different health here or in other part of the world. So getting ready is something that is also for us.
if I can add.
Yeah, go ahead, Stefan.
Okay, now if I can add something, because we have a lot of things that we would like to change really a lot. Since the really beginning, our first error was do not understand the real spreading of this disease. This is true, this is evident for every one of us. And at the beginning, as a clinician, we started too late to protect ourselves. Everyone in the world know that there are several colleagues, also colleagues of mine, that are still fighting against this disease. This change between my personal step 0 to step 1 was too late. Okay, for the future, the idea as an emergency manager is to identify something to predict and something to intercept earlier the crisis. This plague is too big to be effectively insert in an emergency plan. No one can, I think, can think about the number of PPE, the number of procedures, the necessity of dedicated hospital for this kind of plague. However, what we have to learn, this is my personal opinion, is to build up some alert system to start in advance and to think a little bit better regarding the shift from the ordinary system to an emergency system. Thank you.
Excellent. Thank you, Stefan. So I'm just looking at the clock here, and we are very, very nearly out of time. So I will just take this moment to say sincerest thanks to all of our presenters here today, all of our panelists. That was an excellent session, some brilliant insights and lessons learned from your experiences. And yes, definitely applicable all around the world. And there's some very nice comments coming in here as well. So we can see that it was very well received. Also, our best wishes from everyone at ISQua to Dr. Marco De Luca and his family. We hope all is okay there. To our audience here today, just a reminder that the recording for the webinar will be available in roughly 24 hours. So that'll be sent on to you as soon as it's available. And please feel free to circulate it within your networks and with anyone you see you think might benefit from it. If you haven't already seen our COVID resources page, then please feel free to check it out on the ISQua website. We've collated resources from all around the world, which we hope will be of benefit to you. And we also have 2 upcoming COVID webinars next week. One with Dr. David Bates, who will be looking at 2 decades since to Earth to human, and also incorporating some COVID-related experiences into that. And on Thursday, we have Rocco Perla and Lloyd Provost discussing how we can use improvement science and data to better understand and manage the COVID-19 crisis. One thing that everyone at ISQua has been acutely aware of in the past few weeks is the strength of our community and how everyone has come together to rally together to share their knowledge with their network and use their voice to try and do the best we can to manage it in the face of this crisis. So thank you to everyone so much. And if you would like to join the ISQua community, then please feel free to do so as a member. We'd be delighted to have you. So again, just to wrap up, thank you so much to everyone who joined us today, and special thanks to all of our presenters today. Great session, and thank you for the work you're doing, really, and best of luck going forward in the future.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you. Bye.